questions which are about the probiotic, prebiotic, early moisturizer, and etc. in prevention of atopic eczema, especially during the early stage. So there are a lot of recommendations, and most of the guidelines, unfortunately, fail to deliver what we call personalized medicine. Most of the guidelines are very good for policymakers because the guideline will say, based on the current study, most of the study is too heterogeneous in terms of the probiotic strain, the dosage, the regimen, and blah, blah, blah. So not enough evidence to recommend any intervention. That's a typical statement. So if I were the policymaker, I liked it a lot because say, no evidence, I don't allocate budget to you. Yeah. But if a mother say money is not issue, a lot of money, my husband and myself are having severe eczema, I want to try my best. You can also say, guidelines say no need. I mean, the guideline is not designed for personalized medicine. Guideline is designed for upstairs people. They don't want to work, then they use a guideline and say, no, it's not allocate. They're not going to allocate budget to this subgroup of patients. So to understand this, you have to go back to the mathematics of atopic dermatitis. You do know the mathematics and the possible clinical cause, you can make a decision when is the best moment to do something. You look at atopic eczema that I highlighted earlier on, it's a very complex disease. It's not 1 + 1 = 2. You don't spend all your money to do the RAS test, or now we call it immunocap, skin prick test, go down to Tangkat to do applied kinesiology, hoping that you can get one single cause, remove it, you live happily ever after. That's most of parents, they wish that is the way to understand atopic eczema. We know that atopic eczema is not 1 + 1 = 2. You look at the A, the alphabet A in atopic dermatitis is not allergic dermatitis. Means that allergen indeed play a role in the initiation and perpetuation of atopic eczema, but definitely it's not the cause of atopic eczema. When we talk about allergen, often we talk about the food allergen, contact allergen, and aero allergen. It's true, if I have atopic eczema, I have higher risk to get food allergy, at the same time, asthma, rhinitis, and conjunctivitis. This statement is correct, but does not mean that you have atopic eczema. At the same time, you have urticaria or food-induced urticaria due to chicken eggs, means that you'll find the answer to atopic eczema. These are two medical conditions. In the medical report, I will write 2 diagnoses. Indeed, some of them do induce each other, but definitely it's not the cause to each other. So besides allergen, they also have environmental irritants that can irritate and play a role in the initiation and perpetuation of atopic eczema. For example, if today I'm wearing jeans, I'm now in New Zealand, very dry winter. I walk a lot because I have not enough money to use a lot of public transport. I have to do a lot of walking. Over time, the friction might also induce eczema over the hair-bearing area. Same like you use an inappropriate cleanser, the harsh cleanser, you might also end up with dryness and further irritating the skin and end up with eczema initiation and perpetuation. So the eczema can be irritated by all these chemical, physical, and emotional irritants. And if you take a swab over the eczematous area, almost always you can grow some degree of Staph aureus and also lower biodiversity. And we know that Staph aureus, they produce what we call exogenous proteases, and these proteases will digest your skin, make the skin barrier worsen. At the same time, the Staph aureus also acts as a super antigen, can directly stimulate the lymphocyte without the help of a specific allergen, which we call super antigenic effect and induce inflammation. You take a detailed family history, 70% of them will have a family history of one of the atopic dermatitis, and how the genetic affect the manifestation of atopic eczema. First, they cause skin barrier defect because the lack of certain protein and ceramide level. As a result, they are more prone to skin dryness and eczema. At the same time, they over-respond to environmental allergen and irritants. As a result of the genetic predisposition, put them at higher risk of getting atopic eczema. So the role of genetic is well documented. Let's say you look at the monozygotic and dizygotic, the concordant rate among the monozygotic is much higher compared to dizygotic. And similarly, if you take a family history of the patient, if one of the parents has atopic eczema, it's 3 times higher risk for the kids to get it. If both parents are atopic, then about 5 times higher risk. And thanks to the advances in genetic analysis, now we can use this next generation sequencing with millions of SNP, single nucleotide polymorphism, to look for the associated gene. Based on the current study, up to 2018, at least 35 candidate genes in our 20,000 human genes are implicated in the initiation and perpetuation of atopic eczema. And this, no need to remember that. I just want to highlight to all of you that we already know pretty deep about the underlying genetic predisposition of atopic eczema. So among all these genes, 8 of them are related to skin barrier defect, and 27 are related to dysregulated innate and adaptive immunity. And one of the most robustly validated is the filaggrin gene over here. Filaggrin gene, we know that filaggrin, if you have filaggrin gene mutation, you might end up with what we call ichthyosis vulgaris. If you have a homozygous or compound heterozygous filaggrin gene mutation, you are 80 to 150 times higher risk of getting atopic eczema. But on the other hand, having filaggrin gene mutation alone is not equal to atopic eczema. Many of the filaggrin gene mutation patients are not progressed to atopic eczema. To highlight here is that atopic eczema is a complex disease due to relative contribution of many genes and a lot of sequential exposure to environmental factors. So by this interaction, they produce a very complex disease, and this complex disease looks simple, but it's not simple at all. And among those with atopic eczema, some of them onset earlier, some of them onset later, some of them go into long-term remission by 5 years old, some of them persist into early adolescence and adulthood. This is what we call the multi-omic approach of either single gene or polygenic condition. In atopic eczema, the basic ingredients include the genomic that highlighted just now, environmental factor we call exposomic. The interaction between genomic and exposomic is not single direction. In fact, the environment will feed back to the genome via something called epigenomic. Means by alter the expression of the gene without alter the DNA sequence. How do we achieve that? This definitely need generation, is not immediate. They can do it via something called methylation of the DNA, also histone modifications. So these 3 omics, genomic, epigenomic, exposomic, and some authority further subdivide the exposomic, the internal part, into microbiomic. So these are the 4 omics, relative contribution of these 4 omics in different settings produce a condition called atopic eczema. And because of all these omic interactions, they produce a very complex disease that unlikely this complex disease, you can use one single measure to halt the progression of the disease. And just an analogy to describe many genes, many environmental factors to produce a tree called atopic eczema tree. And how do they affect the manifestation? They via the skin barrier defect here, as well as the type 2 inflammation by the Th2 and Th22 cells. And some of them go into remission early, as questioned just now. Some of them have late onset. They only onset after adulthood. Yeah. And this does not end here. We march on to other organs, which include the food allergy, atopic dermatitis, asthma, and allergic rhinoconjunctivitis. Back in 1993, if you look at the progression of these 4 atopic dermatitis, the first one manifests is food allergy. But over these years, they found that it's not true. The first manifestation, in fact, is atopic dermatitis. This partially explained by a hypothesis called dual allergen exposure hypothesis. What is the concept behind this hypothesis is that if you expose the food allergen via a proper route, means oral exposure, you makan makanan, in your gut, you know your gut is a very complete immune school or university. Your gut has 60 to 70% of the whole body immunity sitting in the gut called gut-associated lymphoid tissues. And this gut-associated lymphoid tissue, they have a very complete system to analyze whatever get into your gut through orally. So when you get a chicken protein come in, the houseman go and clap, who are you? You are chicken protein. I will inform my MO. MO will inform the professor. Professor will say, okay, this chicken protein is not so dangerous. Okay, let them go. I get your protein, but you didn't disturb me. I don't disturb you. That is a very mature immune system. But if you expose to chicken protein through your skin is not trained to handle chicken protein. How do you get it? A lot of people avoid high allergenic diet. At the end of the day, if you have eczema or dry skin, skin barrier skin, you take the chicken eggs protein, then you smear it over here, or your mother fried the chicken protein, the chicken eggs, the protein will evaporate, the vapor will stick on the newborn baby, the infant with eczema. If you expose first time or few more times through skin cannot handle this chicken eggs protein well. They will react in an allergic manner. They will fight because they are not well equipped with the engine to analyze it. So this is what we call it the dual allergen exposure hypothesis. You're exposed to food protein via skin exposure, likely you will develop allergy. If you're exposed through oral, then you will gain tolerance. Now, most of the international guidelines do suggest us to go for early hyperallergenic diet like peanut as early as possible. After 4 to 6 months, you can start to give a little bit to the kids. Based on the study like LEAP study, EAT study have shown that early introduction through a proper route induce tolerance. If you do it later, you might induce allergic reactions. In fact, patients with atopic eczema, they have 2 times higher risk of getting asthma and others like rhinitis and also the conjunctivitis. So besides allergic march, we have something called psychiatric march. A lot of atopic eczema patients, because of itch, they don't know how to handle it. The parents also cannot help them. The caretaker also cannot help them. So at the end of the day, they use their own way to overcome the itch scratch cycle. One of the ways is to keep themselves busy. Once they itch, they will go around. My patient come into my clinic, they will just walk around, touch here and there. Another group will be holding a handphone, playing videos, because they know that the only way to get themselves out from this itch scratch cycle is by distraction and focus on other things. So at the end of the day, they end up with something looks like attention deficit hyperkinetic disorder. And among the pubertal age group, they start to develop conduct disorder, depression, and soft drug abuse. In fact, we have heard cases of suicidal attempts also commit suicide because of the very severe eczema that disturb their psychosocial life. Of course, the march is not restricted to physical allergy, also psychiatrics, and third one is financial march. Because many of them cannot go to work, they spend a lot of money, like for example, the biologics and the JAK inhibitors cost few thousand per month. Yeah, so many of them end up with financial march. So this is the possible clinical cause. Not all of them will go through all. Some of them having subclinical eczema with proper treatment, they go into clinical eczema and then get better and then don't fulfill atopic eczema. So atopic eczema is just one of the academic way to classify our patient with eczema in the first few years of life. Does not mean that all of them will get into atopic eczema. Some of them get to this and they already go into long-term remissions. So by knowing the possible clinical cause, then you can intervene them accordingly. You can either intervene them very early, before the onset of any symptom, or you can intervene them later. Or some of you might want to wait until they fulfill the allergic march, then only you want to intervene them. In the interest of time, I'm going to focus mainly on the primary aspect of it. Means before the onset of eczema, before the child lie on the bed and start rubbing like that, sir. That's what we want to achieve today. Yeah. So when we talk about primary prevention, the first thing in our mind is about biotic. We can use probiotic, prebiotic, postbiotic, parabiotic, and symbiotic and minimal antibiotics. So what we call it biotic approach. Others with limited evidence, but people also practice including vitamin D supplement during pregnancy or the omega-3 polyunsaturated fatty acid. Others measures that gaining a lot of attention over the last decade is early moisturization. In fact, one of the study called Stop Eddy study, they use Aveeno product as early as the first 4 days, continue until 8 weeks, and show that they have reduction in cumulative incident of atopic eczema at 6 months by 50%, 50. Yeah. So early moisturizer gain a lot of attention. Others very exciting, but not very easy to do the study, including keeping dogs, found that it's more preventive than keeping cats. But don't ask me the mathematics of if my house got 3 dogs and 2 cats, what is the final result? We don't have that. Ask ChatGPT for that. Others exciting one, including the vaginal fluid and fecal transplant for those decided to go for lower segment cesarean sections. So moving on next, don't expect single intervention. Why I spend the first 10 minutes to talk about the complex genetic and environmental factors in pathogenesis atopic eczema, so that you all know that don't expect applying moisturizer for 2 weeks, you can halt the progression of such a complex disease. So today I'm not going to go through each of them using different study, but I'm going to share with you the principle rather than each of the study to support any of these measures. So in the prevention, primary prevention atopic eczema, we are talking about principles. The first and foremost, you need to use it at the right timing. Combination, don't rely on one single measures. Third one, personalize. Of course, it's very easy to entertain the parents, say that, oh, the guidelines say it's not supported. But you know the guideline is not designed for personalized medicine. And fourthly, you need to use it long enough, not 1 or 2 days or 1 or 2 weeks. Usually need months of intervention. And only finally, before you send the patient off, then only tell them what is recommended by guideline. Guideline should not be here. Guideline should be down here in personalized medicine. So let's take a look at timing. We know most of the thing in our life is about right timing. You have very good ingredients, wrong timing, you don't get any good results. As simple as cooking an instant noodle, you prefer Maggi mee ke atau Indomie, whatever is it. The main thing is, again, right timing. If you start boiling of water, the first bubble bloop out from the base, you put the instant noodle in for 3 minutes, you get a very hard, not well cooked yet. So you have to wait at sea level. You have to wait until the whole thing blah, 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 like this. Then it's 100 degrees at sea level. You put it in for 3 minutes. Immediately take it out. Run under the tap water to arrest the cooking. If you leave it there, they will overcook. So you have to stop it promptly. 3 minutes, stop. Then you get a chewy, springy, QQ textures instant noodle. So at the end of the day, it's about right timing. When it comes to right timing in primary prevention, people say probiotic is good. You start giving the patient at 6 months old, too late lah. You need to start earlier. Or people say keeping dogs is good. You keep the dogs 3 years old, already have severe eczema, then you keep the dogs, not going to prevent lah, it's too late lah. Right? Yeah. So when it comes to this simple thing, again, when it comes to primary prevention, we talk about a concept which is the first 1,000 days of our life. The first 1,000 days does not start on the date of birth. It starts date of fertilization, means include the 280 days in utero. That's why in Bahasa we say, Selamat Hari Jadi is wrong. It's Selamat Hari Lahir. Actually, your Jadi 280 days earlier than Lahir Day. So next time you sing, don't say Selamat Hari Jadi, but Selamat Hari Lahir. Yeah. So even our ancestors always say, Sam soi ting pasap, strike while the iron is hot, melentu bulu biara dari rebungnya. So same thing, you want to prevent atopic eczema, you have to intervene before date of birth, especially when it comes to probiotic. We know that this first 1,000 days is important for many aspects of the child growth, including the brain, 80%, you gain it during the first 1,000 days, the synapses. The skin barrier function also takes time to mature, because in the first 280 days, your baby is in utero, in an amniotic fluid aqua environment, not aqueous, amniotic fluid environment. At that time, there are minimal friction, very stable temperature, and our beloved mother apply Vernix or the internal moisturizer on your skin. The minute you get delivered, you need to handle this harsh, polluted environment immediately, from an aqueous environment to an air-filled, dry environment. Most of us learn a lot about how the heart change, patent, PDA, etc. But a lot of people forget that even skin also takes time to adapt when they're from in utero to ex utero. That is a golden period for us to do something. If you miss that period, the skin barrier might not fully mature over time. And same apply to our innate and adaptive immunity. So just to recap again, the first 1,000 days include the first 280 days in utero and the subsequent 720 days ex utero. First, let us take a look at the probiotic. If you decided to adopt this measure means oral and probiotic, please give it 4 to 6 weeks before the date of EDD, expected date of delivery. Because based on this meta-analysis by Lei Chao et al., using probiotic for long-term effect on preventing atopic eczema, found that only those that have a prenatal component here, prenatal component have a risk ratio of 0.83. Those only have a postnatal component, they don't have a statistically significant risk ratio to support the use of probiotics. Next is about the dog ownership. This is an elegant and interesting study by Beaufort et al. Again demonstrated that only the group B and B plus 3, means dog exposure at birth, was associated with decreased atopic dermatitis. If any of you just delivered your baby 10 days ago, after today's lecture, you quickly go and get a dog, you don't get it. But it's not like, actually, just this study is a bit strict. But in fact, it's recommended by German guideline. Keeping dogs in the first year or first 3 years have a primary protective effect against the development allergy and asthma. But the data on cats, tiger, lion, golden fish, we don't know. So again, don't ask me later whether you get 4 dogs, 2 cats, and 3 goldfish, what is the final effect like? Yeah, ask ChatGPT. Yeah. So next interesting measures that gaining a lot of attention in prevention of atopic eczema is the internal moisturizer, we call it Vernix. Yeah. Of course, we can't apply in utero, but once the child delivered, once you stabilize the patient, the Vernix effect will slowly wean off over the next 3 to 5 days. So preferably in the next first week of life, you need to adopt a good gentle moisturizer and cleanser for kids with high risk of atopic eczema. And this is supported by the Singapore guideline. Moisturizer should be used from birth in infant with a family history of eczema. And this is mainly based on the 2 pilot study, one in Japan, Hari Mukai et al. The other one is from US and UK, joint study, Simpson et al., have shown that if you start applying within the first 3 weeks until 6 months, in these two studies have shown that there are reduction in cumulative incidence of atopic eczema by 30 to 50% at 6 months. Whether it delay or what, but at least it shows some beneficial effect. Unfortunately, subsequent study, two bigger and longer study called BIP and PREVENT ADL study have failed to deliver the similar protective effect. But as you look at these two studies, the BIP and PREVENT ADL study, they do have limitation. Although they are bigger and longer, but the adherence rate is pretty low. The PREVENT ADL study, they're using a petrolatum-based emollients. Only less than 50% of them adhere to this 3 to 4 times per week of application of these petrolatum-based emollients. And the BIP study, although they have higher adherence, but the definition of adherence to me is not that impressive. It means 3 to 4 times per week of petrolatum-based emollients considered adhere to this particular study. In fact, some of the local culture, they use infant massage maybe twice a day or once a day. Even a normal, non-high risk, they're already on frequent moisturizer. And this particular study is only required 3 to 4 times per week of petrolatum-based moisturizer. So because of this, there's another study called STOP-AD study by Carroll et al. In this study, they use Aveeno product and they apply very early, first 4 days before the vernix effect disappear. And to make sure that it's more adhere to the regimen, they keep it for until 8 weeks only. Because once it's too long, then usually the adherence will reduce. So they're using the oat-based moisturizer, which has ceramide and free fatty acid, whole body twice a day. And this is the results. At 6 months, under the intervention group, 18.3% developed atopic eczema, with double over the dose that without the moisturizer. So this is something that is cost-effective, at the same time is safe, as one of the measures among the combination measures to reduce the risk of getting atopic eczema. Of course, there are many more studies, including the PEBBLE study in Australia and a few more. We are waiting for more study to support these measures. Besides the timing, combination is very important. As highlighted just now, atopic eczema is a disease that results from not 1 + 1 = 2, but due to a lot of not modifiable factors like genetics and epigenetics and environmental irritants, allergens, and germs. Unlikely such a complex disease, you apply 2 weeks of Aveeno, you can stop the progression of the disease, right? Always go for combination. You can't expect a single measures you can do all the jobs. It's a bit, your expectation is a bit too much. Yeah, you always have to go for combination approach and not single measures in order to get a good result, including the team to say, yeah, pull together, 1, 2, 3, pull, 1, 2, 3, pull. So you need all this effort in order to stop such a complex disease. So what do I mean by combination? One of the recommendations is that when you decided the probiotic, you also need to decide the prebiotics. Yeah, this is a study by Kukkonen et al. They're combining the probiotic together with a prebiotic, which is galacto-oligosaccharides, have shown that they reduce eczema by odds ratios of 0.74, atopic eczema 0.66 respectively. Of course, at this point of time, some of you might ask me later which probiotic strain are more suitable for prevention of atopic eczema. So there are many of them in the market now. Some of them is for diarrhea, some of them is for this and that. But those that are more robustly validated for atopic eczema include these 4 strains, according to this analysis by Stephanie et al., 21 original study and total of 4,000 over children, Lactobacillus rhamnosus, Lactobacillus paracasei, Bifidobacterium longum, and Animalis. These are the 4, especially Lactobacillus rhamnosus have shown to have, is one of the most robustly validated strain for preventing atopic eczema. If the parents prefer one, then probably I will just tell them to go for this. Of course, nowadays, it's not only combination of probiotic, prebiotic, some of them do combine with postbiotic and parabiotic, means the metabolites of the probiotic or part of the probiotic, we call it the lysate. There are two famous brands in the market. They're using Bitromonas filiformis, Aquaphilus dolomia. These are found in the spring water. Maybe some of you have money or you know the somewhere Jeffrey Chia asked him to give me 1 million. I go to Tambun and get whether is there any specific bacteria in the Tambun water. Because I remember I'm from Ipoh. Last time, whoever had eczema, they do go to Tambun Hot Spring to put the head in, feet inside. They claim that it's improved the conditions. And next, beside the combination and timing, we need to personalize it. So what is recommended is early moisturization, prenatal probiotic, prebiotic, exclusive breastfeeding for at least 6 months. This is my usual recommendation for high-risk parents, children of the pregnancy with high-risk parents. There's another measure, which is the partially hydrolyzed cow's milk formula. This is something that we need to personalize it. Why we need to personalize it? Because it's based on how many percent of the community are going for exclusive breastfeeding, and also the financial income of that particular community. For example, in Malaysia, only about 40% of the population of the pregnancy, they go for exclusive breastfeeding for 6 months. The other 60%, if after we have advised them to go for exclusive breastfeeding, they say, but I cannot, then if that's the case, then you can offer them partially hydrolyzed cow's milk formula. And if myself and we do go to Nepal and Sri Lanka for mission every year, when I was in Sri Lanka and Nepal, I didn't even bother to talk about partially hydrolyzed cow's milk formula because 82% of them are on exclusive breastfeeding for 6 months, and it's too expensive to get the partially hydrolyzed, about 1.5 times more expensive than normal cow's milk formula. But let's say going next door to our neighbor, Singapore, one of the richest countries in the world, only 1% of them able to go for exclusive breastfeeding for 6 months. When they have money, they can't give exclusive breastfeeding. Why not? One of the options is partially hydrolyzed cow's milk formula. In fact, it's recommended by their allergy prevention guideline from Singapore. If breastfeeding is impossible, of course, the definition impossible is always, you can debate and argue, and may consider using partially hydrolyzed cow's milk formula, especially if they are high-risk patients. So this is what we call personalized. Means 睇人講人話，睇鬼講鬼話, that kind of thing. Yeah. So that's one of the recommendation. Another personalized measures is the mode of delivery. Whether you go for spontaneous vaginal delivery, elective C-section, or emergency lower segment C-sections. We know, based on the study, have shown that the lowest risk is the spontaneous vaginal delivery, followed by elective C-section, the highest being the emergency C-section in terms of risk of getting atopic eczema. Of course, we know very well nowadays the indication for C-section is no longer medical indication. A lot of times it's personal choice. Because in certain countries like Turkey, Egypt, of 2 delivery, 1 is by C-section. Malaysia is almost every 4, 1 of them is by C-sections. Because especially Chinese, they believe that the timing is very important to deliver the baby. Otherwise, instead of becoming Elon Musk, become me, not so rich. Yeah. Just analogy, whoever go through this squeeze through the vaginal canal is a bit stronger. Those go through the C-section, not that weak, but it's a little bit less mature. This is my own animation. I deserve a round of applause here because this is the butterfly. Of course, the story said that it's the butterfly allowed to go through this, squeeze through this, the pupa go through the cocoon. They become strong with a strong wing, slim body, and fly towards the rainbow. But this is a bit exaggerated for vaginal delivery and C-sections. But those go through, when they're trying to squeeze through, the surgeon go and scissor here. What happens is that a lot of fluid will accumulate over the body, and the wings, they cannot dry up properly. They get a very obese butterfly and small deformed wings, and they will grounded for life. But of course, this is a bit exaggerated. It's not C-section that become a lembed person, but just to exaggerate that. Yeah. Of course, some of you might ask why whoever go through C-sections in an emergency manner have a higher risk, because usually they give an antibiotic prophylaxis before the C-sections. And in fact, the prenatal antibiotic have shown that it increased the risk of getting atopic eczema, by the study by Elisa et al. So next will be long enough. Of course, some of you might ask, if I decided to go for probiotic, how long? But generally, based on the studies, either 6 months or 24 months. The landmark study, in fact, it goes for 6 months, a study using Lactobacillus rhamnosus in Finland by Kalliomäki et al. From 4 weeks before delivery, 6 months after, using Lactobacillus rhamnosus. And they follow up the patient 2 years, 4 years, and 7 years, have shown that there's a reduction, cumulative incidence of atopic eczema. At 2 years, about 50% reduction. Those on this intervention is 46% develop atopic eczema. Those on intervention is 23%. But this is getting narrow over years. At 7 years, although still significant reduction, but it's not that prominent after 7 years. Instead, 66% without intervention develop atopic eczema at 7 years, compared to around 42%, means from 50% drop to around 30%. Another study in Oceania countries, I forgotten it's Australia or New Zealand, they go for 2 years. Wicken et al., Christine Wicken et al. Have go for 2 years with Lactobacillus rhamnosus H1001. After 11 years of follow-up, they still have this more than 50% reductions in the cumulative incidence of atopic dermatitis. Finally, it's about the guideline. As I said, you need to go through all this. Finally, then only refer to guideline. Don't put the guideline up here. Otherwise, if you use the guideline up here, this is the answer. They usually will say something like this. Due to different types of emollients, probiotic strain, prebiotic dosage, timing, regional influence, blah, 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 a long description, a definitive conclusion could not be reached in this study. Then if you base on this one, done, no need to further explore. But we are talking about personalized medicine and shared decision. In fact, we know that probiotic for immunocompetent child is reasonably safe. And secondly, it's already in practice. You look at the probiotic market in the year of 2024, it's about 2 times of antibiotic market globally, and as predicted, it's going to become 2.5 times more people using probiotic. So this is about the debate or argument or suggestions about primary prevention. I think you all need a rest. Do you want to rest? Toilet break? Can I ask the organizer, do you all want to go for toilet break? Or you want question and answer also?
Dr. Leong?
Yes.
Maybe we can do some questions while some take 5 minutes.
Maybe some break. Can go for toilet. Some want to ask questions, also fine.
We have some online questions. We'll go through a few of them first before we pass to the floor.
Yeah, so Dr. Leong, there are a few questions from the online audience. So if the itch reduces, does it mean that the atopic eczema is recovering?
Yes. But of course, the itch reduction need to be at least 3 to 4 points reduction. That only considered clinical significant. Because sometimes it's not easy, especially for kids. you just have 1 point improvement. Let's say initially it's 8 becomes 7. Of course, it might be significant, but to make it clinically or quality of life improvement significant, we need at least 3 to 4 points reduction. Means that the mother very confident to say, oh, before the treatment is 8, now it's become 5. Oh, I'm convinced. He said, oh, 8, okay, 7 now. And then the kind of Malaysian slang, now 7 then I think not significant. Yeah.
Okay, so there's also another question asking, under what circumstances should we prescribe steroid plus antifungal versus steroid only?
Okay, yeah. I forgot to put up that slide. When do you suspect tinea on top of underlying atopic eczema? We know that atopic eczema, usually they follow what we call bilateral symmetrical pattern according to the age group. In the first 2 years of life, the most common side is both sides of the face, a little bit over here because of the saliva, the extensor surfaces because of the rubbing, and the outer aspect of the lower limbs. Those are the common side in most of the patients in the first 2 years of life. And the older kids, they start to go to the scalp, forehead, in front of the neck, behind the neck, in front of the elbows, abdominal folds, behind the knee in a bilateral symmetrical pattern. And the mother always come to see you, you give them steroid, non-steroidal, emollients like Avinor, they say, yeah, improve. But after that, they are not so compliant, the eczema come back again. Usually they say it's responsive. But now suddenly, the bilateral symmetrical become asymmetry. Means one side and here, this side, no matter what you put, steroid, you put antibiotic, moisturizer, the eczema still, so-called the scaly rash still expanding, slowly over weeks to months. So that's why I always empower the parents to take photo, because sometimes a single snapshot photo are not sufficient. We need to take a photo now, 2 weeks later, 4 weeks later, you look at the margin, how the margin progress. Let's say they are from symmetrical become asymmetrical. First clue that you might need, one of the differential diagnosis is fungal infection. The second one is the margin increase in size slowly over weeks to months. The second clue that you need to consider fungal. The third one is the margin from ill-defined become well-defined. Last time you want to look for the margin, don't know where is it, But now, close your eyes so you can draw the margin out, then you have to think about potentially secondary complicated by fungal infection. And the fourth thing is, of course, in my hospital setting, we can scrap the border of the active migrating margin and to look for any dermatophytes or the hyphae. Once you have confirmed there's a tinea infection, then you need to give 2-in-1. But the 2-in-1, one of the very important things is don't use a very potent steroid, because the steroid may mask the underlying inflammation and you don't have a good parameter to say when is the best time to stop the antifungal. Let's say for patients without eczema, with fungal infection or ringworm over the skin, our advice is to apply antifungal over the area affected plus 2 centimeters beyond the margin. Apply until the whole lesion gets flat, no scaliness, no redness. Apply extra 1 week. This is the usual advice for normal ringworm without underlying eczema. But the problem is over the eczematous area, eczema itself also have redness and scaliness, and the scaliness is exactly the same between fungal infection and eczematous. So if you just rely on antifungal and you use a potent steroid, the steroid may suppress the inflammation and you might undertreat the underlying fungal infections. So if you can identify the fungal infection with a background of eczema, you still can use the recommendation 2 weeks to 3 weeks plus another 1 more week after the lesion improves. But the challenge is a lot of eczema patients, the eczema are quite widespread. You don't know precisely where are the fungal infection. In this case, you need to use oral. If otherwise, they may undertreat the underlying eczema. So you want to use steroid with a background of tinea plus eczema, the steroid is just enough to reduce the itch so that the quality of life improve. But don't use a strong steroid to suppress the inflammation. But otherwise, you lost a good parameter to follow up when is the best time to slowly wean off your antifungal. Yeah. Any other question? Two questions. Two questions from the, yeah, please. Sorry.
Is there a role for genetic counseling in prevention?
Genetic counseling, yeah. Genetic counseling at this point is not easy because the 30 over genes that I mentioned just now, you won't be able to identify by using the usual whole exon sequencing. You can't just send off and get the result back. Because those, you need a special, we call it SMP, the marker to identify this gene. And the 35 gene that I mentioned just now occur in all the patients. Maybe each patient only have 5 of these 35 genes. And these 5, you need to integrate into environment that the patient live. Then you need the ChatGPT to analyze this ding dong, ding dong. Then only you know how many of them will get eczema. So it's not so reliable at this point. But I think in the years to come, people start to use the polygenic risk factor for cardiac disease, same principle. But cardiac disease, they are rich people, there are a lot of investment, they're going to have these polygenic risk factors, stratification, scoring system much earlier than eczema. Yeah. So in fact, they already have this going on using this genome-wide association study to identify the genetic risk of getting ischemic heart disease. But eczema will be many years more to go. Because most of the genes that I mentioned just now, they are not monogenic, they are not 100% penetrance kind of manifestation. Even the filigreens gene mutation, one of the more robustly validated, they only increase the risk. By having the gene mutation alone does not mean that they're going to develop atopic eczema. They just predispose someone to atopic eczema by the risk of around 80 to 150%, 150 times if you have a homogeneous or compound heterozygous. Any other question? Yes.
Is there any medications to prevent, to give to the children?
Is there any medication that
to give to the children to prevent atopic dermatitis?
Yeah, has highlighted just now. If you're talking about primary prevention, means just risk stratification based on family history. In that case, what I normally do, let's say a family are from so-called the well-off, money is not a big problem in their life. In fact, too much money is the burden of their life. In that case, I will ask them to go for early moisturization. Means immediately the patient, the baby delivered, within 4 days before the vernix effect wean off, we need to decide which brand of moisturizer that you want to use. But currently, I'm not going to cite Avinor, but currently the one that more convincing is from Avinor. The study is called Stop Eddy study. So you can start applying twice a day, bathing for the baby of high-risk parents. This is the first measure. Second one, if the parents also agree using probiotic, I ask them to go for Lactobacillus rhamnosus 4 to 6 weeks before the EDD. And once the baby delivered, you can feed the mother, and there's an enteromammary line that will, whatever the mother eats, actually will get to the breast milk and feed the baby. If the mother are not keen to go for exclusive for 6 months, then you can feed the baby with the probiotic Lactobacillus rhamnosus, and together with prebiotic like the galacto oligosaccharide or human monosaccharides. So those are the human milk oligosaccharides. So those are the probiotic and prebiotic. And the third way is get them, if religion does not against it, you can get a dog during pregnancy and after. And next one will be going for early detections. Yeah, so those are the general recommendations that I offer the parents. Okay, good. So next, we move on to next lecture. Are you good? Oh, yeah, okay, yeah. So as highlighted just now, atopic eczema is a disease that due to dynamic interaction between genetics and environmental factors. So means it's multifactorial. And these multifactorial conditions, they end up with eczema, and the eczema have 4 key components. What are the 4 key components? Dry skin, scaly skin, and sensitive to environmental factors, followed by itchiness and scratching activity. Next one is inflammation. Inflammation can be subdivided into subclinical, clinical, mild, moderate, and severe. Subclinical is very early. Sometimes you really need to be very vigilant to identify that. And one of the earliest signs that has a primary care physician is to identify the thing that I mentioned just now. When the child start to do that, that is the earliest moment that you can do something. At that point, of course, you might not need to use steroid base. You can use any moisturizer plus, means moisturizer with avenantramide like Aveeno or other moisturizer with a direct anti-itch, anti-inflammatory property. But once the rubbing area becomes scaly, become redness, then you need to use some medicated cream to arrest the progressions. So next, if you are not managed to control them well, they will progress to infection. Infection will make the skin even drier, and the vicious cycle will go on and on and on. Yeah, so that is the vicious cycle that are well known among patients with atopic eczema. Why we need to know about this? Because you can formulate your regimen according to these 4 key parameters. For infection, obviously, you can use antibiotic, antifungal, antiviral, antiseptic bath. Inflammation, you can use steroid or non-steroidal like tacrolimus, pimecrolimus, crisaborole, tapinarof, and also JAK inhibitors like ruxolitinib. Itch, already highlighted just now, the 11 measures, but don't rely on histamine, antihistamine alone. But now we focus on this, the dry skin and sensitive skin. So the key here is don't just focus on one, always focus on combination approach. So another very important take-home message for atopic eczema management is right timing and right combination and right sequence. What do I mean by right sequence is that a lot of people, although they use all the medication, but at the wrong sequence or the reverse sequence. A patient already having acute infected eczema, they're still talking about using a extra virgin coconut oil, that kind of thing. Yeah. When the fire is really out, put out the fire. Don't ask who start the fire, and don't ask your neighbor to use bucket of water to put out the fire. Get something effective, put out the fire within the next 2 to 4 weeks. Then only we sit down, have a cup of cappuccino, and talk about the long-term plan. So this is the 4 measures that we need to integrate together with modification environment. So when someone already having acute severe eczema, don't bother to talk about stop chicken eggs, get a 8,000 ringgit HEPA filter vacuum cleaner to suck all the house dust mite from the home. Those are not going to be effective. Yeah. So stop the fire, maintain it with, flatten the curve of eczema. So these are the 5 main pillars, and most important of all is what my main expert at Advantage, which is education and empowerment. I always say that in my hospital, our whole team always give at least 30 minutes during the first consultation to all the patients with atopic eczema. We can go from A to Z, and sometimes they ask me, how do you know that you have educated them adequately? I say, you just go to the toilet, you want try to pee, nothing come out, or something very yellowish come out, means you have talked enough until you get dehydrated, means you have done enough educations. So more importantly is to make sure that you combine them. Don't just rely on one thing. A lot of parents have the false impression that if I put twice the moisturizer a day, I get 30%. I put 4 times, I get 60%. Put 6 times, I get 90%. So from virgin become extra virgin, become virginous moisturizer. It does not work in that way. No matter which one you choose, they still have their own limitations. So always go for combinations. So my last lecture, don't know, maybe it's last lecture, is going to talk about this gentle moisturizer and gentle cleanser. And dryness is one of the very consistent features among atopic eczema patient together with itch. Dryness, scaliness, itchiness, redness, whippy red, lichenification is a progression of dry skin. Of course, not all of them will end up with eczema, but a significant proportion of them with dry skin like this have a much higher risk of getting atopic eczema. So this is an Indian boy, born normal, start to develop dry and scaly skin, first noted around 3 months old. As highlighted just now, the first 280 days, why a newborn baby with this dry skin does not manifest on day 1 of life, because our beloved mother applied internal moisturizer called Vernix in a very cozy environment, very stable temperature, no ultraviolet injury at all. I don't know whether you all remember or not the first 280 days of your life. That it was those days that you got no hand-foot injury, no ultraviolet injury, no friction, in fact, because you are in the amniotic fluid sac. Yeah. Of course, you also pass urine and bathe yourself back then. I don't know whether you remember. I have a big memory about that part of my life. Yeah. So this is a dry skin. Once they delivered, slowly, the harsh environment slowly will convert a relatively normal skin, become dry skin. Once the skin gets dry, the epidermal cell turnover will become disturbed. They become sticky, and they can't shed off the thick scales on top. This is especially over the exposed area, because exposed area will get drier much faster than the hidden side. So that's why it's more over the outer aspect, less over the internal, less over the body. Like in this case, it's more severe over the outer aspect of the exposed area, less over the body, and less over the face, and in a bilateral symmetrical pattern. If the patient suddenly stay in the air-conditioned room for too long, this will become more severe. Then they start to get involved in a lot of outdoor activity, this dry skin will get better. And overseas, they always describe that summer will make this ichthyosis worsen, and winter will make the ichthyosis worsen, but during summertime, they get a bit better. And just to illustrate what I have highlighted just now, the first 280 days in our life, we are in a very nice, well-replicated, very stable temperature environment. But once you get squeezed out to this polluted, harsh environment, the looks normal skin will become dry and scaly skin. But of course, not all of them will progress to eczema. And in this case, what is the diagnosis? And this case, the diagnosis is ichthyosis vulgaris. How do we make a diagnosis of ichthyosis vulgaris? It's based on, again, the morphology, the scales, dry, fine white to brownish, fully adhere to the underlying skin. About the distribution and pattern, is more severe over the exposed area, more severe over the extensive surfaces in a bilateral symmetrical manner. And they are usually normal at birth. They are not Gallodian in nature, and first detected around 3 to 6 months of life, and get worsened during winter years and winter months, and also if a lot of indoor air condition. And if you examine other family members, I'm not surprised that you will get another 1 or 2 people having a similar problem, because it's autosomal semi-dominant. And they are associated with a condition called hair scale around the hair follicles, called keratosis pilaris, and palmoplantar hyperlinearity. In fact, myself also having this. If you do a lot of jogging with a tight clothing, this might get irritated, get inflamed, and get worsened over time. And this is the hyperlinearity of the palm and soles. All these features support the diagnosis of filaggrin gene mutations. And next case is an older kid, 5 years old, dry scaly skin since 4 months old. Again, it's more severe over the exposed area. In this case, over time, they start to affect the lower abdomen. Lower abdomen. And this is the distribution and the pattern of the rash. Minimal over the face. The face has many dryness, but no obvious scales on top of the skin. So just to summarize again this case, also same scales noted, but it's more extensive, more drier skin, background skin, and over time, this case does not stop at the scaly stage. In fact, it progressed to eczemated stage. So this was a child when the child was 5 years old. At 10 years old, it became like this. So it means the dryness, itchiness progressed to eczema in this particular case. And both cases have the same diagnosis, which is filaggrin gene mutation, but they have different destiny. One remain has dry skin, one progressed to fully established atopic eczema. So this is the answer for the second case. So bear in mind, in dry skin, the dry skin does not stop at dry skin. Once you have dry skin, the epidermal cell turnover will be compromised. The dead skin will accumulate at the top of the surface that becomes scaly. And when you have dry skin, scaly skin with a lot of environmental frictions, they will progress, evolve into itchy and dry skin. So that is the progression of the dry skin, become itchy, become scaly, and over time, they become subclinical eczema and clinical eczema. All this is not caused by one single factor. It's progression, cumulative effect of multiple environmental factors, include a harsh cleanser, always exposed to air-conditioned room, and even the paint on the wall, they will release the formaldehyde. The formaldehyde will fly in the air and will stick over the skin. Over time, also is one of the factors to cause skin barrier defect. So all these are about our urbanized community. The air pollution, the air quality are the factors that contribute to dry skin and over time become atopic eczema. So what is the underlying molecular and cellular defect among patients with atopic eczema? This is our cross-sectional view of our skin. We know one very important layer of our skin, which is the stratum corneum. The stratum corneum is the end result of the epidermal cell turnover. This stratum corneum plays a very important role to prevent the water evaporation, at the same time prevent the invasion of the allergen, irritants, and also bacteria. So this is the animation to illustrate the process. Every 4 weeks to 6 weeks, basal cell layer, the cells, the keratinocyte will move up to the surface, losing its nucleus and form this very strong stratum corneum. And every cycle normally takes about 4 to 6 weeks. And this will prevent the water evaporation and also invasion of the allergen, irritants, and germs from external environment. And one of the widely accepted model to represent the stratum corneum is called brick and cement model. In this model, the brick represent the corneocytes, the dead corneocytes, and the cement represent the ceramide cholesterol, free fatty acid in between the ceramide. One of my young patients, he said, Dr. Leong, I don't like so ugly to use brick and cement to represent my skin. I want something more funny and exciting. I asked him, what do you want? He said, I want SpongeBob. I said, why not? It's a good way to illustrate, use this to illustrate our stratum corneum, in which the SpongeBob have this humectant effect, means absorb the water and surrounded by a layer of lipids, which is the butter. So we have this SpongeBob and butter model. Similarly, the SpongeBob represent the dead corneocytes and the ceramide cholesterol and free fatty acid represented by the butters or the mentega. So what happened among atopic eczema patients? What is obvious is that they have a defective mentega or the lipid bilayer. And studies have shown that this layer, the ceramide, cholesterol, and free fatty acid, all are reduced in atopic eczema patient. That's the reason why most of the atopic eczema moisturizer, they do put ceramide, cholesterol, and free fatty acid into their preparation. If you have a very balanced ratio of the ceramide, cholesterol, and fatty acid, they will form a nice lipid bilayer. But unfortunately, in atopic eczema patient, they have reduction of all three, especially ceramide. As a result, they can't balance each other. They form a lot of microscopic pores in between. To fill in these pores to prevent water evaporation, you need to have this either physiological lipids or the non-physiological lipids. In hospital, because physiological lipids is much more expensive, usually we go for non-physiological lipids like Vaseline, Bactrolatum, and aqueous cream with dimeticon. Whereas the physiological lipids means that they use exogenous ceramide, cholesterol, and fatty acid to replace and repair whatever defective here. So these are the different type of physiological lipids replacement, ceramide of different ratio. Some brands that use 111, 211, 311, they don't have 911 as far as I know, but of course they use different ratio to replace and repair what is defective among atopic eczema patients. And in hospital, we use the Bactrolatum base, dimeticon base, aqueous cream, and mineral oils. In Aveeno, what they use is the lipids from the oats, and also for skin barrier repair, they use the lipids in the form of triglyceride, ceramide, as well as the sterol with free fatty acids. And the study have shown that the Aveeno is not only replace it exogenously, they also induce endogenous productions. Means they not only give you fish, they also teach you how to fish for fishes. Yeah. So the study have shown that the oat lipids induce ceramide formation in the skin cells. You can see this is the oat lipids moisturizer. Over a duration of 7 days, the total ceramide level over the stratum corneum had increased significantly. So by doing so, you can replace and repair what is defective at the stratum corneum. Next is to increase the water holding capacity, which is the humectant effect of a moisturizer. The main humectant or physiological humectants is from the porphyrogreens. The porphyrogreens will be metabolized into filigreens in the stratum corneum, and they finally become natural moisturizing factors. The natural moisturizing factors in our skin include the urea, sodium PCA, free amino acid like arginines, as well as the sugars and others. And again, different brands, they integrate different exogenous humectant. Some use the sodium PCA, some use arginine, some use urea to improve and increase the water holding capacity of our skin. And in terms of Aveeno, what do they use? Aveeno, they use the protein, the moisturizing factors, the humectant to increase the water holding capacity. And this is the others, including the glycerin, also will improve the water holding capacity. Thirdly, we know that our skin surface, the pH is around 4 to 5.5, depending on different region and different ethnic group. But in general, the average is around 4 to 5.5. It's important to maintain the pH gradient and the pH around 4 to 5.5. The reason because if you have very high skin surface pH, they will activate the proteases activity. Proteases will digest your skin and cause skin thinning. Yeah, this by maintaining the skin surface pH around 5.5, the enzyme proteases will be balanced by the anti-proteases. But once you increase the skin surface pH to 7, the proteases activity will increase and cause skin thinning. And this will facilitate the water evaporation and also invasion of the allergen irritant much easily. And at the same time, cause microbial dysbiosis. And this is the effect of applying the colloidal oats present in Avinos, show that not only improve the skin surface pH, they also improve the skin microbiota. And how do they achieve it? By this called prebiotic, the beta-glucan. Beta-glucan will feed the good bacteria on our skin so that you will rebalance the skin microbiota, which is defective among atopic eczema patients. So lastly, it's about the microbial dysbiosis. Of course, many years ago, when any kids with acute eczema flare, according to guideline, we give a course of antibiotic. But we know that that's not a proper way, because the minute you kill the Staph aureus, after a couple of weeks to months, they will get recolonized again. The reason because if you don't improve the eczema, the skin surface pH, they will attract the same lousy bacteria to sit back over the affected area. This is the normal skin. Normal skin have a high biodiversity, means there are different types of bacteria on our skin. But over the eczematous area, I say over here, they are dominated by Staph aureus. And because of the inflammation, these red dots represent the Staph aureus. They become low biodiversity and high density of Staph aureus. The Staph aureus will cause skin barrier defect via exogenous proteases, also induce inflammation via their super antigenic effect. In fact, a study, one of the landmark study by Professor Heidi Kong et al. Have shown that before eczema flare, there's an increase in density of Staph aureus. So this is clinical flare. Before clinical flare, the density of Staph aureus will increase. At the same time, the biodiversity of the microbiota on the skin will reduce accordingly. So if you take a swab over the eczematous area, 90% of them you manage to identify Staph aureus. In fact, the more severe the eczema, the more likely they will grow Staph aureus over the affected area. And by using Aveeno, have shown that they will increase the skin microbiota, the biodiversity, and reduce the density of the Staph aureus. And next, how do you choose a moisturizer that preferred by your patients? As we always say, there's no single moisturizer suits all the patients. You really have to tailor it according to the background of the patient, the budget of the patients, and the patient preference. We know that by giving adequate moisturizer, have a steroid-sparing effect, especially for those with mild to moderate atopic eczema. And you look at all the international guidelines, they always emphasize moisturizer, moisturizer, and moisturizer, regardless whether they have mild, moderate, or severe atopic eczema. When you want to choose a moisturizer, you need to make sure that the moisturizer have both components, the humectant and occlusive effect. Occlusive means they put a layer on the skin surface to prevent water evaporation, and the humectant will increase the water holding capacity. So when you look at the ingredients, you need to make sure that they have both together to be considered a good moisturizer. The second one is the formulation of the vehicle that they use. We know that the moisturizer, they come in different form. The lotion is more watery. It's suitable for patients that have a lot of outdoor activity. But for the lazy patients, they usually prefer the ointment base, because ointment base is more long-lasting. But if you use the ointment base for an active child, usually they don't like it because they become too oily and occlusive. So whether you use an ointment base, cream base, or lotion base, it depending on what is the activity of patient, firstly. Secondly, what type of activity and area that you want to apply. Let's say over the hair-bearing area, like over the scalp, the hairy chest, hairy axilla, if you want to use the ointment base, it's very leche, they will say very messy. If you want to apply over the scalp area, we prefer lotion, spray, or cream base. If you want to use an ointment base, the hair bearing area, after 50 strokes, then only you can put evenly over the affected area and can see become not very cosmetically friendly to the patient. And some of the kids get teased by their friends that they become orang minyak. Yeah. So if the child always stay indoor, especially young kids, you can use the ointment base. If the child always in the outdoor hot humid weathers, most kids prefer cream base or lotion base. And another important thing, obviously, is the cost of the cream. To apply a person like me from head to toe is about 20 grams. A newborn baby is about 5 grams. If you get a moisturizer, apply twice a day over the of an infant. Morning you apply 5 grams, evening apply 5 grams. 5 days, the 50 grams will gone. Yeah. So if you sell the patient 50 grams, after 1 month they still have 25 grams, means they have not used it adequately. So this is the calculations. Of course, some of that indeed is very expensive. So practically, how do I advise them? I advise them to get a basic one for the whole body over the hotspot. Over the hotspot one, you can consider using the 5-star emollients. We know that all kids with atopic eczema, they do have their hotspot. The first 2 years, as I highlighted, both sides of the face, and the older kids usually over the forehead, in front of the elbows and behind the knee. In fact, the Aveeno have done a cost effectiveness study. If you choose the right patients, you use it adequately together with the non-steroidal and steroidal, they are cost effective. So another important thing is the patient preference. So usually I will put different cream in front of the patient, ask them to choose, and show them how to apply it. And if the patients say that, oh, last time I used this one, it become more itchy after that, usually we should not try a new one during acute eczema flare, because during acute eczema flare, the skin barrier already compromised. Even though you put water also, the child will complain of pain. So don't try a new one during acute flare. Cool down the inflammation first. Try on one side for 5 to 7 days. If the condition get better, then ask the patient to continue using the same one over the as long as possible. Of course, for atopic eczema, we need to tailor it according to the molecular and cellular defect that are associated with atopic eczema. Besides using the occlusion humectant, because of skin barrier defect, we need to make sure that they have done a pre-marketing study, make sure that they do not induce allergic reactions, minimal risk of irritation, and does not disturb the skin surface pH. Even better if they have integrated the direct anti-itch, anti-inflammatory property. For example, in Aveeno, they have avinantromide. Avinantromide present in the active colloidal oats of Aveeno, they can stop all 4 simultaneously. Have the avinantromide have shown that they have effect to improve the skin hydrations. See the hydration improve, and the skin hydration improve initially. Once you stop, they reduce again. At the same time, the avinantromide have shown to reduce the itch score. After 14 days, the itch score reduced by around 30%. But once you stop, the itch come back again. So at the end of the day, it's still combination, but itself have some added effect to the combination approach. Inflammations, again, have shown that the avinantromide have the direct anti-inflammatory property that reduce the skin pro-inflammatory cytokines, include the TNF-alpha over the site that you apply the Aveeno. And finally, once you improve the dry skin, reduce the itch, improve the inflammation, improve the skin surface pH, they will restabilize the skin microbiota. I have shown that the microbial diversity increase back to almost normal once you apply the oat-based moisturizer. So this is a product that have a 4-in-1 effect. Of course, alone might not be effective for severe inflammation. It's good, especially during the maintenance phase over the hotspot area. Yeah, with this, I would like to end my presentations. Is there any more question, or you have time for the last lectures, or you prefer to ask question? Any question?
Doctor?
Any question? Yeah.
Hello, Dr. Leong.
Yes.
My name is Dr. Yao. Just want to ask, since atopic eczema should be treated very early during the infancy period, in your hospital, is there a mechanism to identify these babies in the postnatal ward before they are sent home?
Yeah. In this, very difficult to identify early because the minute the baby come out, they are still from a very nice aqua environment. And usually by 24 hours, they're already discharged. But sometimes what we do is we just advise them, anyone with family history of atopic eczema, atopic dermatitis, this subset, we do advise them to look for early sign of eczema, which means that they rub against the clothing, rub against the mother's shoulder. But at the same time, because in the hospital, it's very difficult to promote something they are not supported by guidelines. The big hospital usually follow guidelines, but if any individual parents, let's say one of the staff approach me, then I will advise them accordingly, like what I advised in my second lecture just now. Early probiotic, get pets at home, preferably dogs, early moisturizer, and etc.
It's true, like you said, the initial part we cannot see any changes because they're protected by the casus vernix.
Yeah.
But you know, it'd be good to identify this. But to do that, the postnatal want me to have a guideline, maybe to probe into the family history of this child having any problem. Because like you said, there was some role in the treatment, prevention, or reduce the incidence of atopic eczema during the antenatal period. You know, so it would be sad if we can miss these babies when they're born and they were covered by the vernix protected and not be able to see. If they can identify this, then probably, you know, they'll be told to come back for follow-up.
Yeah.
Once the protection is no more, then we can institute treatment early.
In fact, the ONG specialists and the pediatrician usually are the targets of the probiotic company. Right. Yeah. For dermatologists, usually they only manage the established eczema. You ask any dermatologist role of probiotic, they say, no role. Yeah. Because they are used to become hero in putting out the fire of eczema. If no eczema means dermatologist no business. Just kidding. Yeah.
Thank you. Thank you.
Yeah. And of course, the pediatrician at ONG, they have a lot of lectures by so-called commercial lectures by the milk company about role of probiotic, prebiotic. And hopefully now with study, stop at this study, then Avino can do more talks for the ONG, because they are the one who advise the parents before the first, during the first 280 days of the in utero life of the patient. Yeah, we should train them earlier rather than once they already have established eczema, then only go and busy get a dog or cats from somewhere. Yeah.
Dr. Leong, there are some questions from online audience.
Yeah.
For infant patients with food allergies, such as egg, cow's milk, that causes eczema to flare up, when can we be challenged, as these are very important source of nutrition for baby's health?
Yeah. So usually we divide, from food allergy point of view, usually I divide my patients with atopic eczema to two groups. The first group are those with pattern eczema, means the eczema is only over both sides of the face, over the extensive surfaces. Those patients, unlikely the food allergy play an important role. Unlikely whatever you consume will waste themselves over both sides of the face on it. Those are more of external environment. This subset of patient, I don't bother at all to talk about food restrictions. Only those with very extensive eczema, I can't get pattern out of the eczema, atopic eczema patient. These are the subgroup might benefit from food restriction and food challenge. And when is the best time to do a food challenge? Bear in mind, whatever tests available in the private lab, which include the skin prick test and the so-called food-specific IgE test or RAS or immunocap, those are used not for eczema, those are for immediate onset reactions. Those are not designed for atopic eczema. Those are designed to identify one of the potential triggers for atopic eczema. Yeah. So for this subset of patients, a more reliable way is a home challenge first. If there's no severe reaction before and the child is not malnourished, usually we advise them to do home challenge. How do you do home challenge? The first prerequisite is to stabilize the eczema first. You don't stabilize the eczema, there's no way you can identify the flare is due to food allergy or during the flare during that challenge period due to environmental factor. Let's say a patient with severe eczema come into your clinic. The mother say, oh, yesterday I give the child sotong, the child get more itchy. Then I say it could be due to hot weather. Recently Malaysia is getting very hot. Or maybe due to the child having stress because 2 days ago got exam. There are so many explanations that might explain the eczema flare. So in order to do a challenge, you need to stabilize the eczema, let's say from 100%, at least down to around 20 to 30%, stable for the good 2 weeks. Then you do challenge one by one. The day that you decided to do the challenge one thing at a time. And after you introduce the suspected food, over the next 24 to 48 hours, preferably the child in a stable environment. Otherwise, whatever flare, there are more than one reason that can induce the flare. Exactly like someone having diarrhea 8 times per day now, you cannot challenge a child with diarrhea with cow's milk from 8 times become 9 times. Oh yeah, the extra 1 time is due to the cow's milk that I challenge a patient. So you still have to use extensively hydrolyzed cow's milk formula to induce remission of the diarrhea. Then only you challenge it, depending on what type of reaction you want to observe. If you are observing for immediate onset, you just need to observe for 2 to 6 hours. But you want to observe for delayed onset, which is very difficult, you have to observe until 48 to 72 hours. So based on a German study, have shown that around 50% of the patient with atopic eczema, at the same time with food allergy, they belong to immediate onset. Means that someone with eczema on both sides of the face, that takes the chicken eggs, within 2 to 6 hours, they get swollen eye, got itchy urticaria. This is the most common form. The second form, initially they have urticaria, later the eczema get worsened. This is the second form. These 2 forms, I think we can identify them. The third form is the most difficult one. In fact, that form, not every people agree that that's due to food allergy. Is after you have taken it, after 48 hours, the eczema flare up. This one, you need to repeat the same one again, at least 2 to 3 times to confirm it. So that's why food challenge in a setting of atopic eczema is not really gold standard. You still need a lot of, just a lot of bias factors that can affect the final results. Yeah, hope that I've explained the questions. Any other question?
Yes. Dr. Leong, what's your thought on the role of virgin coconut oil on dry skin? And
Virgin or extra virgin?
Virgin.
No, just kidding.
Yeah.
Yeah.
And the role of urea cream and biological treatment for xeroderma.
Biological treatment for?
Xeroderma.
Xeroderma. Biologic. Oh, that one I'm not sure what he's trying to ask. But back to the first question first. The virginity of the moisturizer or the
Coconut
olive oil is based on the oleic acid. But virginity of the coconut oil, actually, I don't know how to decide how virgin is the coconut oil. It's self-claim. Lah. They just say, I'm extra virgin, I'm super virgin or whatever. Yeah. So olive oil and coconut oil, indeed, coconut oil is favored than olive oil for atopic eczema. Because the oleic acid in the olive oil have shown to have keratolytic agent, a keratolytic effect. In fact, cause skin barrier defect and increase in water evaporation. So I only use extra virgin or virginous olive oil for severe psoriasis with thick scales or crater cat, but I don't use it for atopic eczema. On the other hand, sunflower seed oil, coconut oil, they do have study to support that they have anti-inflammatory and antimicrobial effect. But at the end of the day, don't rely on moisturizer alone. When a patient already has significant established eczema, I don't think any of this super virgin thing can solve the problem. That one is usually for the second stage or third stage of the maintenance, might works, but it does not work alone. Yeah. So urea cream is a humectant below 10%. Urea cream more than 10% become keratolytic. We use urea cream 40% to soften the nails. We use 20 to 30% for the thick ichthyosis patient, 10% and below to improve the hydration. The only disadvantage about urea is that if you have a lot of broken skin, they induce stinging sensations. So if for hydration effect, preferably 5% and below. If you want keratolytic effect, can go a bit higher. Yeah. Any other question?
Dr. Leong, one last question.
Yeah, good.
Yeah, what if the patient has wheat allergy, can Aveeno be used?
Oh, okay. This is another very common question. But bear in mind, in the Aveeno, it's the active colloidal oats. It's not the whole wheat that you pancho and put on the skin. So the study to support the use of oats, the active colloidal oats, is that they did a pre-marketing patch test to test it. Furthermore, oats is not a highly allergenic protein. If you look at most of the IgE reactions, the oats is not high in the list. And in fact, what is used in the Aveeno is not really the whole oats component. It's just one of them called active colloidal oats. Yeah. So so far, there's no evidence to suggest that it's induced allergic reaction or induced future oat allergy. Okay, and we have how many more minutes? We have 14 minutes. Let's go for the last part, or there are more questions before we go for dinner. Again, this part, to be honest, you can take a nap because it's quite complicated, mainly to show off only, to show off that dermatologists a group of people that have brain tissues. It's not just about Botox and fillers only. Yeah. So when you look at inflammations, for many years when we look at inflammation, we look at inflammation in a very superficial manner. Inflammation, back to our student years, they go for this pain, go for rubor redness, calo, and tumor, and loss of functions of the affected area. But as far as skin is concerned, the pain become itch as one of the main features of skin inflammations. And we can divide inflammation in many ways. First, based on which organ is predominantly affected. From liver, we call it hepatitis, lung, we call it pneumonitis, and skin, we call it dermatitis. And today, I'm going to focus on dermatitis. How do we subclassify dermatitis or eczema? We can subclassify them based on the cause of the disease, whether it's acute, subacute, or chronic, or acute on chronic, subacute on chronic, or based on the degree from subclinical, become clinical, mild, moderate, and severe. And we also can divide them based on the histological findings, whether they affect the superficial skin, we call it dermatitis, or down in the fat, we call it panniculitis. And histologically, we base on which cells are the dominant cells that dominate the inflammations. And before this, if based on this, a lot of time, the mainstay of treatment is still steroid. Back in 1952, a group of scientists extracted a component active ingredient from the cow adrenal gland. They call it substance H, and formulate it into cream, apply on a patient with skin eczema, and found that 1% of this substance H have a clinically significant anti-inflammatory effect. And subsequently, this substance H become hydrocortisone acetate. And later, over the next 20 to 30 years, they're trying to modify the hydrocortisone molecules. They got more than 20 different types of active steroid cream, include the most potent one, which is clobetasol propionate. So that was during the years that we didn't have much. From 1952 to year of 2000, we only have one group of cream that have a clinically anti-inflammatory effect, which is steroid. In the year of 2000 onwards, we have another group called tacrolimus, pimecrolimus, which is under topical calcineurin inhibitors. In 2016, we have another group called crisaborole. In the year of 2020, we have another group under topical JAK inhibitors. This was based on the era that we didn't have all these molecular results of inflammation. In the year of 2000, if not mistaken, 2007 onwards, we start to identify that in the T helper cells, there are at least 4 types: Th1, Th2, Th17, Th22. And all of them involved in different types of skin inflammations. And from there, you have this type 1, type 2, and type 3 inflammation, which is different from the gel and comb hypersensitivity reactions. This is based on the T helper cell and the cytokines. And why do we need to know about this? Because this gives us an idea where do we target our formulation. We know steroid basically act on all the cells, from fibroblasts to endothelial cells to keratinocyte to the immune cells and etc. So they are not targeted. So the scientists trying to look for targeted therapy. And the first step to targeted therapy is to understand which particular cells and cytokines involved in different type of inflammatory dermatosis. And to understand this, we need to go back to this complex immunity of our skin. This is our skin. Our skin have, from immunity point of view, we have 2 components, the innate immunity and the adaptive immunity. The non-cellular innate immunity is contributed by our physical barrier, the stratum corneum, and also the microbial barrier, the high biodiversity skin microbiota, further supported by chemical barrier. By maintaining the skin surface pH around 4 to 5.5, it will chase away the Staph aureus and improve the skin microbiota. Others include the toll-like receptor. We know that in our superficial skin, the immune cells and the keratinocyte, they have a receptor called toll-like receptor. They identify certain patterns that commonly found in pathogenic bacteria, whether like corticoid acid, LPS, and some RNA and DNA from the bacteria and viruses. And this toll-like receptor, they no need to inform the headquarters. When they see certain pattern, they will react promptly and initiate the inflammation and kill that suspected bacteria and viruses. And beside that, our skin also produces a natural antibiotic called antimicrobial peptide, the beta-defensin and catalycidin, further supported by all these cellular components of the innate immunity, including some of the new cells called innate lymphoid cell type 2 and type 3. This is related closely to atopic eczema. This is more for psoriasis. And the middleman between the innate immunity and adaptive immunity is our dendritic cells. These dendritic cells, there are many forms during inflammation. Some of them evolve into inflammatory dendritic cells called IDAC. and some of them are from the myeloid origin, and some of them are plasmacyte in origin. So there are different forms of antigen-presenting cells. Once they get the antigen, they will present to the regional lymph nodes. And in the regional lymph nodes, they have the naive T cells based on the local cytokine milieu and as well as the genetic predisposition. Some of these naive T cells differentiate and proliferate into Th1, Th2, Th17, and Th22. Of course, this looks very complicated. For immunologists and dermatologists, this really helps us a lot to understand all this inflammatory dermatosis. And how these cells interact with each other, they produce different languages in the form of cytokines. For example, Th2, they produce IL-4, 5, 13, and 31. This is Th2. They produce these cytokines to interact with others. And Th17, they produce IL-17, IL-22, and even the keratinocytes, they produce alarmin, TSLP, and etc. So this will communicate with each other and form this complex map of interactions. Although this map looks complicated, but it's truly enlightening for us. I'm already in dermatology for the last 22 years. The first 15 years, we still talk about steroid moisturizer. Only recently, we start to have this new targeted therapy that help us to take care of the patient with severe atopic eczema. Based on this histological, phenotypes, genotype, transcriptomic, and proof of concept study, they identified 3 major pathways. The first pathway is the Th2 induced, stimulated by IL-4 and produce IL-4, 5, 13, and 31. Another 2 is IL-23, Th17, and IL-12, Th1. This is the key cytokines or key pathway for atopic eczema. This is a key pathway for psoriasis. Why is it important? Because by inhibit the IL-4 and IL-13, you can improve at least 75 to 90% of most of patients with severe atopic eczema. And for psoriasis, by inhibit IL-23, IL-17, achieving PASI 100 means 100% remission is no longer a dream. In fact, it's a reality in many of the cases. Of course, they don't act independently. They do have a lot of crosstalk among them. But at least based on this, we know how to formulate a targeted therapy to help the patient with, especially with severe itch and severe atopic eczema. Briefly, we go through the atopic eczema. In atopic eczema, the key cells is the Th2, further supported by Th22, and in certain patients, especially the chronic patients, they're also supported by Th17 and Th1. And another advantage of knowing all these cytokines and dominant Th cell is it helps us to see the similarity among all these atopic dermatitis patients. For example, the same Th2 cytokines, it explains not just atopic eczema, it also explains the underlying immunopathogenesis of allergic asthma, together with others, including the eosinophilic esophagitis, as well as a chronic allergic rhinoconjunctivitis with nasal polyps. And see, all these are related to these same cytokines, but the same cytokines in different organs, they will manifest with different phenotypes. That's why using the medication called dupilumab, they can inhibit the Th2 cytokines. All these are already indicated in a clinical practice to help this group of patients. In fact, some of my patients, by hitting the atopic eczema, the asthmatic control also better during the course of the treatment. And what is why we need to understand all these cytokines and cells? Because it gives us the idea which target we should focus. If you use steroid, of course, when you shoot, it's like almost 1,000 arrows out. Maybe 2 will hit the target. Indeed, the condition improves, but there are a lot of collateral damage to the surrounding tissues, including the fibroblasts, the endothelial cells, and keratinocytes, end up with a trophogenic effect. So what is targeted therapy? Targeted therapy means we already identified which pathway which cytokines is involved, and we can go very near to the targets and hit it there and then, and have minimal collateral damage. So briefly about this treatment, the reason why I want to emphasize this is because whoever have a patient with moderate to severe atopic eczema, we should try to manage your patient first using combination of steroid, topical tacrolimus and pimecrolimus, using a right cleanser, for example, from Aveeno and moisturizer. You have optimized it, counsel them how to modify the environmental factors. You see the patient 3 times, yet more than 10% of the body surface still have the eczema, and the itch is still remain more than 5/10. Please refer to your dermatologist, pediatric dermatologist, or whoever are well trained to use biologics. Because the longer you wait, the more lichenified the lesion, the more difficult for us to reverse it. So how do you identify 10%? I say you use the palm size of the patients and measure it every time. Ask them each from 0 to 10, what is your scoring? You just keep doing it. After 3 consultations, you still not manage to reduce the itch less than 5, and the body surface area still more than 10% affected. Don't wait and see anymore. That's one of the very important message, because let us decide whether we can convince the parents to use something higher than what you are using. Before this, it's very difficult to convince the parents, because before these biologics are available, what are we using for moderate to severe atopic eczema that not responsive to topical creams? We use something like cancer drug, MTX. We use prednisolone. We use cyclosporine for transplant patients. We use azathioprine. Most of the parents are not very keen, because once you are on this, you need to go for regular blood taking. So it's not easy to convince them. So most of them will still end up with frequent moisturizer, topical, steroid, non-steroidal combination. But now, let us talk to them and let them decide. Never know, maybe they afford to go for one of these biologics. Just briefly to show you, I don't want to spend too much time on this targeted therapy. Just want to show you some of the effects of this medication. And this is one of the patients having severe atopic eczema. Despite on topical cream, they don't see much improvement. And this is after a single dose of the biologics. And you can see there are at least 75% improvement after 4 weeks. But of course, if you wait too long, they already become lichenified, then you won't get the very rapid results. For example, the case that I've shown earlier on, it's not here. Yeah. So this is another case. It took us 52 weeks also to convert a depressed child to smiling kids. And again, it's by this combination. Even though you are on Dupilumab, does not mean that you no need to put the patient on moisturizer. You still need combination at the end of the day, because this treatment is not curative. They still need combination approach. And especially over the hotspot area, they still have eczema, and you can still rely on your topical steroid, non-steroidal, and topical moisturizer to handle this area. And with this, I would like to end my presentation. Thank you very much for your attention. So it's 6:30, yeah.
Thank you, Dr. Leong, for the insightful sharing and lectures. So ladies and gentlemen, you can approach our representative at the back of the hall, as we have prepared some Aveeno samples for you to try, and buffet dinner will be